Hello, thank you for joining us for today's webinar to help you navigate the revenue cycle management aspects of the Patient-Driven Groupings Model. We will review the impact of PDGM on the revenue cycle and share operational, clinical, and financial best practices to ensure a smooth transition as we move through this first month of the new payment model. My name is Molly Casey, and I'm the Vice President of Marketing for Axxess. Before we get started, let me tell you a little bit about Axxess. We are a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from David Hoover, Vice President of Revenue Cycle Management for Axxess, and Jennifer Osburn, Senior Clinical Consultant for Axxess. Before we get started, just a couple of housekeeping items. Following this webinar, we will provide everyone with a link to the slides and a video recording of the webinar. Additional information about PDGM, as well as tools and resources to help you navigate the changes, can be found on our website at axxess.com/PDGM. David and Jennifer, take it away.
Our objectives in this presentation is to understand how PDGM will impact revenue cycles for agencies, understand CMS processing for claims, and discuss potential technology solutions to streamline operations. Let's first talk about the HCHRG calculation. Under PDGM, admission source and timing is either community early, community late, institutional early, or institutional late, combined with the clinical groupings from the principal diagnosis reported on the claim, in addition to functional impairment from the OASIS item, low, medium, or high. Comorbidity adjustment could come from a secondary diagnosis on the claim that results in the HCHRG and the calculation of the HCHRG. Some quick PDGM billing facts. For episodes, this is either start of care or recertifications that begin 1/1/2020 or after. The 60-day episode remains intact, but the unit of payments changes to 30-day billing periods. Two 30-day payment periods within each 60-day episode, and each 30-day payment period will require a RAP and a final claim. Some quick facts about RCM under PDGM. Fiscal intermediaries will not begin to process any claims until January 6th. We've already had some delays on this from mentioned for Max from CMS regarding moving it to the 14th already, and this is related to issues that they have on their own software. PDGM is a change for them also, so we could see some additional changes to this as we go through PDGM. Medicare Advantage plans are not required to use PDGM methodology. We are seeing some that are mentioning that they are going to be moving to that PDGM methodology, but again, requires a change on their payer system, so we might see this throughout the year. Early timing will only qualify for the first billing period. Admission source will be determined by acute and post-acute discharges, and we'll talk about how that's going to affect in the bill and the final claim as it is sent to the max at the end of each period. Medicare can make adjustments on a final up to a year. This coincides with Medicare's filing requirements, and so any payment that comes from an acute or post-acute could change how PDGM is calculated. Any start of care performed after 1/1/2020 will pay using PDGM, and any finals on episodes with start of care prior to 1/1/2020 will continue using the PPS system. Recertifications performed during the last 5 days of December that have an episode start date of 1/1/20 will pay PDGM and must use OASIS D1, which means the M90 date must be 1/1/2020. Some quick dates to remember. January 1st, 2019 is when an agency was certified would not be using RAPS in 2020. So any agency certified as a Medicare agency after January 1st, 2019 will not be using or will not be paid on a RAP. They are still required to submit a RAP in 2020, but will not be paid. October 31st, 2019 is when the finalized rule came out. In December 27th, all recertifications for certification periods beginning 1/1/20 must use a 1/1/20 date on the M90, the Moon 90. January 1st, PDGM begins. That's 2020. And January 1st, 2020, implementation of the Oasis D1 also begins. On January 6th, CMS begins to process PDGM claims. Just as we mentioned before, that is now out to January 14th, and we could see some additional changes as we move into PDGM. January 1st to 2021, RAPS will only be used as a notice of admission. That's the 20% RAP payment will be reduced to zero, but the RAP submission is still required to make sure that CMS is aware of admission of that patient to a home health agency. We'll talk about that later on in the presentation. In January 1st, 2022, RAPS will be placed by NOAs, which is Notice of Admissions. So PDGM and RAPS. So we talked a little bit about this on our dates, but again, a little bit more detail. So agencies certified on or after January 1st, 2019 will submit RAPS every 30 days, but will receive no RAP payment. Agencies certified before January 1st, 2019 will continue to submit RAPS and receive a split payment. That split payment will not be the 50 or 60% as we have been accustomed to. It will be decreased to 20% under PDGM for any RAP. This is a temporary move for CMS to eliminate the RAP itself as a request for anticipated payment, but they still need to have a method to identify when there is an admission to a home health agency.
All right. Thank you, David. So let's get a little bit more into the PDGM and the RAPS and the transition over to how we're going to get into the notice of admission and the elimination of RAPS. So we know with the final rule that was posted October 31st, 2019, CMS has laid out this plan to eliminate RAP payments altogether and transition to a notice of admission in 2022. So basically the way this is going to work, currently under PDGM in 2020, agencies which were certified for Medicare services in 2019, they will continue to submit RAPS just like everyone else. However, they will get zero payment for their RAPS. In those cases, the RAP is only acting to show who the agency of choice is for that beneficiary. In 2020, all agencies will actually continue to submit RAPS. As we said, those that are newly certified in 2019 will get zero payment. All the other agencies who were certified before 2019 will get 20% RAP payments when they submit their RAPs. Now, that will change in 2021. All agencies at that point in 2021 will submit RAPs that will pay 0%. And those RAPs' only purpose in 2021 is going to be to serve as notification of who the agency of choice is for that patient or that beneficiary. Now, the thing that's going to be a little bit different is that there will be a RAP penalty if that RAP is not filed within 5 days of the start of care. And that penalty will equal to 1/30 of the estimated payment for that 30-day period for each day that notification is late. For example, if you don't submit that payment, if you don't submit that RAP by, let's say, day 10, that means that you will not be paid for the first 9 days of care. So whatever that amount is, we're going to see an example in just a bit, will be your penalty. In 2022, they're going to eliminate the RAP altogether and introduce a different way to establish the beneficiary's agency of choice, and that's called a notice of admission, or NOA. And that penalty will be assessed as well in 2022 if that NOA is not filed timely, which again is within 5 days of your start of care. And the late penalty, as we know today, as it's been introduced, will be exactly the same. It's 1/30 of the payment for each day that notification is late. So let's look at this on a calendar. When you're trying to figure out if you're submitting your RAPs timely, and again, this is for 2021, the reason we're bringing it up today in 2020 is so that as we're looking at our processes and we're looking at our orders management and all the things that we have to refine under PDGM, we are already looking to refine those to the point that we can get this stuff out the door within 5 days. Because beginning in 2021, we have to have that RAP filed within 5 days of the start of care, or we're going to have a penalty assessed to us. So in this scenario, we have a start of care on Thursday. That start of care date counts as 0. The RAP must be sent by day 5. So let's say that for this 30-day period, we've finished our OASIS, we've pulled everything together, we've got our grouper estimation of about $2,300 payment for this 30-day period. But we don't send our RAP out until day 8. What we see here is that a penalty is assessed for the first 7 days. So what CMS is going to do is look at 1/30 of the $2,300 times the 7 days that we were late, and we're looking at, in this scenario, about a $536.67 penalty for not getting that RAP filed within 5 days of the start of care. And I don't know about you all, but for me, that's a pretty significant hit.
So some quick considerations when you're managing your claims. So not only are we doubling up RAPs and finals with PDGM, but we're also duplicating a lot of other claims activities. So we have eligibility verifications we need to continue to do prior to claim submission. We have rejections, duplicate claims, overlapping services, coordination of benefits, and eligibility issues. All rejections that are dealing with just normal processing are going to be duplicated because we have twice as many claims. Return to providers could be doubled up also, because you could have return to RTPs during the first period and the second period, as well as ADRs. Postings and adjustments are another thing. Not only do we have to send out 2 sets of claims, but we also have to have postings for 2 sets of payments. And hopefully that's more than the return providers and rejections. Secondary filings is another issue. If you have any secondary filings that have to occur after that, of course, you would double that up also. So let's talk about some episodic claim requirements. For RAPs, or request for anticipated payment, we have OASIS completed, locked, or export ready, verbal orders from the MD received and documented, the plan of care is created and sent to the MD, and the first visit completed. Second billing period should only require the first visit because everything else should already be there. On the final claims, we're looking at the OASIS entered into key system within 30 days of assessment, which is the MOO 90 date. The face-to-face and the certification statement is completed, and all physician orders are signed. Visits completed and posted, and the RAP has been processed. Talk about some filing timing. Under PPS and PDGM, there's a few things that are a little bit different, but what you'll find out is just really when you start the time, not necessarily the time that you have to perform it. So under PPS, OASIS must be submitted to keys within 30 days of the assessment date. Under PDGM, OASIS must be submitted 30 days from the IKEYS assessment date. Final must be submitted under PPS within 60 days after the end of an episode, or 60 days after RAP, whichever is greater. And under PDGM, the final must be submitted 60 days after the end of the billing period, or 60 days after RAP payment date, whichever is greater. Again, you're talking a final being 30 days versus under PPS being a 60-day episode, but that's really the only change. The timing to get that completed remains the same. Under PPS, the RAP will be canceled if the above is not met, and then under PDGM, same thing. Finals also can be billed within 1 year from episode end date, and same thing for PDGM. Just a requirement under CMS, you have a 1-year filing deadline.
So what we're looking at now, we've got a visualization or a graph here of how home health PPS revenue cycle worked. And what, you may still have some episodes that are paid under PPS, and the difference between how PPS is calculated, the HIPS and HRG scores, versus PDGM is significantly different. As we all know, with home health PPS, everything is calculated from the OASIS, and that OASIS calculates your HIPS and your HRG score and your grouper, and then it's put into the key system, We go ahead and create and submit our claim, and CMS takes our claim under PPS and looks at what's in the key system to make sure that HIPS and HERC score match. Then they go in and look at what we've sent in on the claim as far as visits and so on, and all of that together is what generates and validates on final whether or not this is correct and whether or not there needs to be corrections or adjustments and so on. But basically, it's all based on what the agency has submitted. That's going to be completely different than what we see in PDGM, and we're going to let David speak to that next.
Thanks, Jennifer. Under PDGM, the thing is the CMS is going to take more of the activity. As you can see in this diagram, we complete the OASIS, the home health agency completes the OASIS and creates the claim. But other than that, CMS will perform everything else. So ultimately, you've heard under PDGM that the only thing that really matters is the claim, other than the functional assessment on the OASIS to determine payment. This is why, because once you submit this information into the key system, CMS will take that information, they will calculate what the HIPS, the grouper and the HIPS code are, process everything, check eligibility in a common working file, do any adjustments as necessary, and then receive the final processing through a remittance device for payment. So PDGM really is more of a hands-off instead of mirroring what CMS is doing for the home health agency. Basically, we're going to provide information and CMS will process everything.
Okay, next we're going to talk about some payment adjustments and the different types of payment adjustments that we had under home health PPS will continue under PDGM. For example, you see on the diagram here, one of the major differences is rather than looking at a 60-day episode of care in PPS and looking to see if that 60-day episode qualified as a LUPA or a partial episode payment or PEP or an outlier, instead of looking at it in 60-day periods under PDGM, they're looking at each 30-day period, each 30-day payment period, to see if that 30-day payment period is going to qualify as a LUPA or a partial episode payment or an outlier. So what they do, they look at that 30-day period, which is, of course, placed into one of the 432 home health resource groupers or HRGs, and they look at that claim and see if the number of visits during that 30-day period is below one of those 432 LUPA thresholds that are assigned per each HRG score. If we've met the LUPA threshold, which is the number, if you see a LUPA threshold of 5, that means we have at least 5 visits. If we've met that LUPA threshold, then we get the full payment for the 30-day period. However, if the LUPA threshold is 4 and we only make 3 visits, then we are paid a LUPA rate, which is a per visit rate for the 3 visits that we've completed. And again, that's looked at per 30-day period, which is significantly different than our PPS period of 60 days. The next thing that they look at is to see whether or not there was a partial episode payment. Now, this generally occurs when the patient either transfers from one home health agency to another during a payment period, or they transfer from traditional Medicare to a Medicare Advantage plan or vice versa. Or maybe they even discharge from the agency and they're readmitted during the same payment period. Again, under home health PPS, if that happens within a 60-day episode, it's a PEP. Under PDGM, if we have any of those scenarios that happen in a 30-day period, it becomes a partial episode payment. Okay? And then lastly, we have outlier payments. They look to see what the utilization is for that 30-day period. Again, not the 60-day period, but the 30-day period. And if it's a higher utilization than their threshold calculations, that 30-day period will be paid as an outlier as well. So what we see is that those same principles are there. They're just applied to different payment period timings. All right, so let's look again. We've talked a little bit about that LUPA threshold, but we can't revisit this enough. We still have plenty of questions about LUPAs. Remember, your LUPA is low utilization payment adjustment. The difference between a full episode payment and a LUPA is that with a LUPA, you are paid a national standardized rate for each of the visits and visit types that you make in that 30-day period, rather than receiving that full episode payment. Currently, under home health PPS episodes, the LUPA threshold is 5 for every single patient, no matter what. If you make 5 visits, you get the full 60-day episode payment. Under PDGM episodes, however, there's a LUPA threshold for each of those 432 case mix groupings, and you have to at least meet that threshold assigned to that case mix grouper or that HRG in order to avoid your LUPA. Again, what that means is you may have a threshold of 2 to 6 visits for each 30-day period, and it applies up to, not at the threshold. In other words, if your LUPA threshold is 6 and you make less than 6 visits, you make 5, 4, 3, 2, or 1, you are paid per visit for the number of visits that you did. They do talk about the LUPA add-on. If you don't know much about a LUPA add-on, it's only an additional amount of money that applies for starts of care in 30-day periods where the total number of visits is at or below the LUPA threshold. So if you have a LUPA on your start of care first 30-day period, which is below the LUPA threshold, sometimes they will add on a little additional money in those scenarios only, okay? With the PEP, we've already visited that a little bit, but again, remember, the biggest thing here you want to think about is you're looking at your 30-day periods. To avoid your PEP, you want to make sure that your beneficiary does not transfer to another agency, that you don't discharge or readmit them to your agency or another within that 30-day period, or the PEP can also occur when that patient changes from traditional Medicare to a Medicare Advantage plan within that 30-day period. Now, when we're talking about readmitting and discharging, we know there are some scenarios that CMS has talked about that can potentially cause a PEP. Specifically, the scenario I'm thinking about is in order to adjust your institutional versus community, what CMS expects us to do if we have a transfer and the patient goes to an acute care setting, then we are to do a transfer. If during that transfer they end up in a post-acute care setting, during that same 30-day period, CMS expects us to discharge that patient and then readmit them whenever they're discharged from the post-acute facility so that we can get the institutional adjustment again when we readmit. Now, there's some question about that. CMS has not told us a lot about it, except that they expect us to do this. In that scenario, depending on what's going on with that patient, you might very well run into a PEP situation if you discharge and then readmit. However, that would be the only way you're going to get an institutional credit if the patient goes from acute to post-acute setting outside that 14-day window and the patient's been transferred to another setting. Because we know the institutional for post-acute only counts in the first 30-day period. If the patient transfers during the first 30-day period and they are in the hospital and you do a resumption of care and they've been in the hospital within the 14 days prior to the next 30-day period, then you will get an institutional credit. However, if the patient has transferred the first 30 days and they went to a hospital setting and then they transferred from the hospital to a SNF, for example, and stayed in that SNF for a period of time, if you don't discharge and readmit them when you do your resumption of care, you will not get an institutional credit in that case. So that's why there's a little bit of a talk about whether or not that's a good idea or not in a PEP and so on. But just bear all those scenarios in mind and feel free to ask us other questions if you'd like. Let's look at this PEP example to just kind of illustrate here. We've got our two 30-day periods here, January and February of 2020. If we discharge that patient on February the 14th, for example, we discharge that patient and we get them back within that same 30-day period, that's going to be a partial episode payment for that patient. They're looking to see if we discharge and readmit in the same 30-day payment period. And oftentimes that's confused with the 60-day gap in care, which is required to go from a late episode to an early episode. But in this case, for your PEP, we're looking at if the patient's been discharged and readmitted either by your agency or another agency in that same 30-day period. And if that's the case, then that becomes a partial episode payment. All right, now let's talk about outliers a little bit. Now, your outliers, the way that they were calculated changed a few years ago with the final rule. We used to base outliers solely on the number of visits per episode. And if the number of visits passed a threshold that CMS established, then that payment would become an outlier. A few years ago, they changed that, so it's not only the number of visits, but it's the number of visits plus the time in the home during the visits. And they're looking at this in roughly 15-minute units. It's not exactly 15 minutes. It may be 24 to 30-something minutes equal 1 unit, but they're roughly 15-minute increments. What they do is they look at the number of visits, the time in the home, and they calculate the total number of units, and they look at that based on a fixed dollar loss ratio and decide whether or not that 30-day period is an outlier. One thing that has changed in the final rule is that fixed dollar loss ratio under PDGM is going to be 0.56, which is a little bit lower than the prior fixed dollar loss ratio, which may mean that you might see less outlier payments than you did under PPS. That doesn't mean the percentage has changed. It's still 10% per year as the number of outliers that can be paid. What I'm saying is that episodes that might have qualified for an outlier under the previous payment system for you might not qualify under PPS just because that dollar loss amount is a little less. So what that means is that under PDGM, that same episode that might have calculated as an outlier might actually not under PDGM because that fixed dollar loss percentage is a little lower, so you may not quite have the same percentages. All right, next we're going to talk about a significant change in condition, which is known as an other follow-up, reason for assessment number 5. SCICs came to be again. We had these very early on when we transitioned from retrospective payment to PPS. We saw SCICs go away, basically, because SCICs didn't affect payment in any way. Agencies decided it was not worth the effort for the most part, and you didn't see other follow-ups when there were significant changes occurring. So in 2018, with the revision of the conditions of participation, we saw SCICs reintroduced to us, and we were told that we are to perform an other follow-up when there is an unanticipated change in the patient's condition, otherwise known as a significant change in condition. The key here is understanding that a significant change is something that is going to greatly impact your plan of care. You're going to have to revise your plan of care, and it's something that you didn't see coming when you established that plan of care initially. In these cases, what we're required to do is to perform an other follow-up. It looks a lot like a recert, but the type is different. It's a reason for assessment number 5. It should be titled other follow-up in your software program. The reason this is important is if that SCIC is completed in the first 30-day period, it can impact your final claim. Because what CMS does when they're processing that final, they go back and look at the functional scores from the most recent OASIS that's on file in IKEYS. So if you're going to be doing a SCIC in the first 30-day period, make sure it's completed, make sure it's on file with IKEYS before you send your final, especially if that functional scoring changes. Now, each agency should have a policy on when they're going to do a significant change in condition follow-up and how that's going to be processed and making sure that it's exported timely and so on. It may be that your policy says something like you're going to do it on a case-by-case basis, and the clinician will call the clinical supervisor when they notice a significant change. That's real important to have that piece in your policy because, according to OASIS guidelines, you only have 48 hours from the time you identify this significant change to actually complete your assessment. So you need to refine your policies if you're not sure about all that. The other scenario that we're going to talk about for just a moment that will affect billing has to do with resolved conditions. When PDGM was introduced, we were told that there were going to be scenarios where our plan of care, our OASIS, and our final claim didn't match, and that under home health PPS they always had to match, but under PDGM that they don't necessarily have to match anymore. The claim doesn't have to match the last OASIS on file. And the scenario that we came up with to kind of talk about that has to do with when conditions that were present the first 30-day period resolve. And it's not an unanticipated change that they resolved. We figured that it was going to happen, and now our change of focus is different in the second 30-day period. In those cases, we would have to go in and update our final claim for the second 30-day period, which now wouldn't necessarily match our OASIS anymore. For example, if you have a patient who has a resolved primary condition or they have a new primary diagnosis for the second 30-day period, but it's not a significant change in condition in this case, so you didn't have to do an OASIS. What you have to make sure you do is to change your coding on your claim. The process to communicate this clinically and for billing in your agency needs to be established. You need to be thinking about how you're going to determine that this is the case for the second 30-day period and how you're going to communicate that to billing. Now, Axxess, we came up with a great solution called a change of focus form. And what this is used, it's a task that you can actually schedule toward the end of the first 30-day period when a SCIC is not to be completed. It's not a significant change. But we do have something else going on the second 30 days that we need to focus on. For example, maybe the patient had pneumonia when they were admitted, and they also have hypertensive heart disease with heart failure. And that pneumonia resolved the first 30-day period. And so we don't need to have that on our claim anymore. According to coding guidelines, as a matter of fact, we're not supposed to code resolved conditions. So for that reason, pneumonia would fall off, and the primary focus for our second 30-day period would be the hypertensive heart disease with heart failure. When that would happen, what we do in the Axxess system, when you go in and schedule this change of focus form, it allows you to talk about why you're doing a change of focus, and it also allows you to resequence and delete and edit your diagnoses just like you would need them to be on your claim for the second 30-day period. When that form is completed, your new diagnoses will flow automatically to the claim for you so that you don't have to go in and rekey those in. Okay? I'm going to let David talk about some of the other technology solutions that we have available to us next.
So a couple of things on technology solutions just to be aware of that have kind of significant impact and make your life a little bit easier, make your processes a little bit more efficient. No payment RAPS. We should record those at 0. Again, we're trying to make sure that we have an accurate accounts receivable. We don't want to be expecting $1,000 to come in on a RAP when $0 is going to come on that because your date is January 1st of 2020 or 2021. Also, dashboard tracking of OASIS and plan of care status. So to make sure that those things are you know where they're at, to make sure that the claim is ready to be submitted or the RAP is ready to be submitted. You want to make sure we have much less time to do that now. So we want our systems and our technology to make us aware of where we're at with those. Real-time OASIS validation. As you're completing the OASIS, to make sure that everything is done as you're completing the OASIS, that you don't have to go backwards and recomplete it to make sure that that OASIS is accurate and complete as quickly as possible. Mobile technology for speed and accuracy, that's really to help your clinicians to make sure the technology should help you get everything completed and your visit completed while you're at the visit. That's the whole goal to everything that we need to do. Again, with only 30-day billing periods, it's essential that we're not tracking down visits to try to make sure that they're completed timely. We need to complete them while we're there at the visit. Interoperability for referral sources and contract therapies. So this is really kind of engaging everybody that's outside of your agency to make sure that all the information is completed and ready to go so that when we submit a final claim, it is a final claim and it has everything that we need for that final claim. Physicians have signed off on all orders. Any additional therapy or visits are completed so that we can submit a complete final claim. Physician's portal for transmitting plan of care. Again, the electronic format to get your physicians to communicate to you is much more effective than trying to track them down. Plus, it also gives tracking mechanisms so that you know where your plan of care is at all times. Ability to pull sections of the OASIS for physician review for certification and inclusion on the medical record. Again, as we're communicating this information back and forth to the physicians, the more information, the more complete view that we give them of the patient's plan of care, the better off and faster they're going to be able to make resolution to whatever their objectives are and be able to respond. So this is all about doing things more quickly and more efficiently and having more information there. So also on final claims, QECs are, make sure that we are identifying those codes that can't be used or can't be grouped. So we need to make sure as soon as one of those pops up that you can identify those or not allow those. In our system, we do not allow those once they popped up, and we give you a warning that that is not a valid code. PECOS verification during intake. We do not want to find out that a physician is not PECOS or in PECOS at the billing. We want that at verification so that we can resolve that and get that taken care of early before we expend any efforts or any cost associated with that patient. Physician portal for signed orders. Again, we talked about that a little bit. The more communication that we can do electronically, not only is it faster and it should be easier to use, but also has documentation that we can follow. Full visualization and processing of claims in a single location. With all these claims that are coming out, 2 RAPS, 2 finals, and different variety of stages, there's no sequencing right now required in PDGM, so we could have multiple billing, multiple episodes with multiple billing periods open. So we want to be able to see all these claims and what status they're in and what's going on with each one of them. Eligibility verification, again, through the intake and throughout the episode, if payers change and on demand, we constantly need to make sure that we are submitting to the right payer and doing the right processes for each payer. Perfect example, Jennifer mentioned before, is moving from traditional Medicare into a Medicare Advantage or vice versa. We need to make sure that we capture that quickly and deal with it in 30-day periods, because that could affect how it could delay our reimbursement. Dashboard tracking of billing requirements, making sure that we know how we want to be able to manage a claims process and its life cycle, and we want to be able to see every component of it. As soon as we see a claim get into a situation that it shouldn't be in, get delayed or stopped or rejected, we want to be able to see it, identify it, and deal with it quickly. To make sure that we can get the RAP submission, make sure all the orders are completed, make sure all the visits are done, and make sure the OASIS submission is completed. We want to make sure all those billing requirements are done quickly so that we can identify those things and get the bills out as fast as possible. Right now, we're at the very front end of PDGM in our first 30-day billing period, and we really won't see anything. And I've advised everybody, make sure that you're doing your QA extensively right now to make sure all that information is there, so that 1st of February, when we submit the first finals, you'll be able to do it quickly and get it out and get compensated as quickly as possible.
We know that as you're working through PDGM, you're going to definitely have some questions that maybe weren't addressed today, or you want further clarification. Feel free to send those questions to us here at Axxess by using the address that you see here, pdgmquestions@axxess.com. Again, that's pdgmquestions@axxess.com. Thank you very much. And Molly, close us out.
Thank you, David and Jennifer, for sharing your wisdom and insights to help us all prepare for the implementation of PDGM. Don't forget, we will provide everyone with a link to the slides and post a video recording of the webinar on our website, axxess.com. Axxess is ready for PDGM, and we are here to help you. Live training webinars will show you the PDGM features in our software that will help your organization thrive. To access our full suite of PDGM educational resources, go to axxess.com/PDGM. There you'll find education on the fundamentals of PDGM and how the payment changes will affect your agency, answers to frequently asked questions, and tips to protect your revenue under PDGM. Thank you for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions.